Welcome to JACC This Week. I'm Harlan Krumholz, Editor-in-Chief of JACC, and this is our issue for August 12, 2025. This issue features a mini focus on amyloid heart disease, with a set of original investigations and expert commentaries that reflect just how far the field has come and how far we still have to go to ensure that everyone can benefit from these scientific advances. We'll start with the context, why amyloid matters and what's changing. Then we'll cover the full content of the issue, beginning, by the way, with two important non-amyloid studies. Okay, what's the background? Well, as you know, amyloid heart disease is a restrictive cardiomyopathy caused by extracellular deposition of misfolded protein fibrils within the myocardium. The two most common forms are due to misfolded monoclonal immunoglobulin light chains, AL amyloidosis, and misfolded transthyretin protein, ATTR amyloidosis, which can either be hereditary or wild type. These amyloid fibrils accumulate in the interstitial space between cardiac myocytes, leading to impaired myocardial compliance, diastolic dysfunction, and ultimately heart failure symptoms. Cardiac amyloidosis should be suspected in patients with unexplained left ventricular wall thickening, heart failure with preserved ejection fraction, or characteristic imaging findings, especially when accompanied by systemic features such as neuropathy or carpal tunnel syndrome. Of course, the rationale for the recognition of looking for these early signs is that early recognition is critical, as specific therapies and prognosis differ between amyloid subtypes, and delayed diagnosis is associated with worse outcomes. Medications for amyloid heart disease act through several distinct mechanisms, targeting either transthyretin or immunoglobulin light chain amyloidosis. The ACC/AHA guidelines recommend transthyretin stabilizers, such as tafamidis or acoramidis, as the first-line therapy for ATTR cardiac amyloidosis. These agents bind to the thyroxine binding sites of the TTR tetramer, stabilizing it and preventing dissociation into monomers, which is the rate-limiting step in amyloid fibril formation. Gene silencing therapies reduce hepatic production of TTR, either by small interfering RNA or antisense oligonucleotide mechanisms, thereby lowering circulating TTR and reducing substrate for amyloid formation. They're approved for ATTR with polyneuropathy and also cardiac involvement. Amyloid fibril disruptors aim to destabilize and promote clearance of existing amyloid deposits, though the clinical benefit remains unproven. As an aside, AL amyloidosis therapy targets the underlying plasma cell dyscrasia with agents that aim to suppress production of amyloidogenic light chains. Emerging therapies include monoclonal antibodies that promote amyloid clearance and gene editing approaches to permanently reduce TTR production. I mean, this is an amazing time for this particular condition, which at one time, not in the very far past, really portended an awful prognosis. So the issue starts with an editor's page, a breakthrough with a burden. I've co-authored it with Michelle Kittleson and Kushal Kadakia. What we say is that ATTR, tafamidis, acoramidis, vutrisiran, reduce mortality, preserve function, improve quality of life. But look, their prices are staggering. The list prices range from a little more than $250,000 a year to $500,000 a year. We say, quote, the next chapter of the ATTR-CM story should not just be about what we achieve in the laboratory. It must be about what we deliver to every patient who stands to benefit. Clinical innovation has outpaced access. This piece challenges us to close the gap and to think about how we can make these accessible and affordable for those who need it. Okay, let's take care of the two papers in this issue that are not about amyloid and get those out of the way. First, compression stockings for vasovagal syncope. This study sought to compare the effectiveness of lower extremity compression with thigh-high compression stockings versus sham stockings for the prevention of vasovagal syncope. Why does it matter? Why were we interested in this study? Well, vasovagal syncope is common, disabling, and pretty poorly treated. It disrupts lives and increases the risk of injury. It would be good to have more evidence-based therapeutics to be able to use to help these patients. This trial, the COMFORTS 2 trial, randomized patients to wear either active or sham compression stockings. The key result, unfortunately, no reduction in overall recurrence. There were fewer episodes occurred while stockings were worn, and that was the key thing about this study. It's hard to get people to wear thigh-level compression stockings. Among the 266 participants, mean age of 39 years, about 60% were women. During 12 months of follow-up, Vasovagal syncope recurred in 29% of the participants in the treatment group and 34% in the control group. At JACC, we don't mind publishing negative studies. We think they can be informative. The question just has to be important. The editorialists, Liu and Pellegrini, say, quote, "The trial adds important insights to the pathophysiology and treatment of VVS. Compression therapy remains a mechanistically sound concept." They have a pretty optimistic outlook. They say compression therapy and thoughtful stratification of vasovagal syncope phenotypes and innovation in compression strategies may yet yield meaningful benefit for those most in need. There's something else I liked about this study. I was excited to see a sham-controlled trial in a field full of uncertainty. It didn't give a magic solution, but it taught us something that I think we can have confidence in. The next study is DOAC versus warfarin in frail older adults. The purpose of this study was to evaluate, in the combined AF dataset, the impact on clinical outcomes of switching frail, elderly AF patients from VKA to DOAC. Why does it matter? Well, frail, elderly patients with atrial fibrillation are at high risk of stroke and bleeding. Here's the question: should they switch from warfarin to a DOAC? The combined AF study pooled data from 4 major trials: RELY, ROCKET AF, Aristotle, and Engage AF. What they found was that switching patients reduced stroke and systemic embolism, reduced intracranial and fatal bleeding, but it increased GI bleeding. Net clinical outcome was pretty neutral overall, but favorable in a few subgroups. The study authors said based on these findings, after shared decision-making, switching to DOACs is a reasonable choice for frail, elderly, VKA-experienced patients to reduce stroke and systemic embolism, death, and the most serious types of bleeding, intracranial bleeding and fatal bleeding. Here's a key quote from the editorialist. "Taking these findings together, we believe the treatment choices in frail, older individuals who are stable on VKA should be framed in the context of a shared decision-making process, considering the overall benefit of DOACs versus warfarin and the consistent effect in reducing stroke and systemic embolism, intracranial bleeding, and fatal bleeding in frail older adults at the expense of potential increase in the risk of gastrointestinal bleeding." Look, these are patients we see every day. This study gives us data to have smarter, more individualized conversations and help make sure that what is chosen is aligned with the preferences, values, and goals of the patient. I guess in my thinking, most people would prefer to avoid stroke and systemic embolism, intracranial bleeding, and fatal bleeding, and at the expense of this increase in gastrointestinal bleeding. Okay, let's get back to the amyloid studies now. This is, in fact, a mini issue on amyloid, so let's go. The first one is a vutrisiran echo substudy by Carola Jering, Scott Solomon, and a list of outstanding investigators. The purpose of this study is to investigate associations of echocardiographic measures of cardiac structure and function with the primary outcome and to assess whether favorable changes in cardiac structure and function with vutrisiran are associated with improvements in outcomes. Why it matters? Well, this drug is beginning to get some momentum, and understanding structural changes are key to tracking response in ATTR-CM. Here's what they found. Vutrisiran attenuated decline in LV and RV systolic function. It improved diastolic function by month 12, and a variety of echocardiographic measures were associated with prognosis. Here's a quote from the study authors. "Baseline measurements in LV and RV systolic function and multiple indices of diastolic function provided important prognostic information in patients with ATTR-CM above and beyond the well-validated biomarker-based staging system. Vutrisiran improved diastolic function by 12 months and attenuated decline in LV and RV systolic function at 18 months. Michelle Kittleson took on the editorial, and here's what she said, quote, "The results of this HELIOS-B echocardiographic substudy offer a tantalizing glimpse into a future in which therapeutic decision-making may be guided by an accurate assessment of prognosis and response to therapies. Nonetheless, it's important to ATTR-CM management that several questions remain unanswered. Is there relative superiority of tafamidis, acoramidis, or vutrisiran? Is evidence to support a benefit of combined therapy with TTR stabilizer or TTR silencer?" I think this is important. Michelle is one of our editors, and one of the key things that was brought up in the discussion at the editorial meetings had to do with whether or not this is about vutrisiran alone. How does it manage with combination therapy? What's going to be the best approach forward? Of course, this trial couldn't really address that. Nevertheless, I think it's exciting to think about how we can tailor therapy, not just based on risk, but on dynamic feedback from echo. The next study is another vutrisiran study, a biomarker substudy led by Matt Maurer and Mariana Fontana and colleagues. The study sought to evaluate the association between the risk of cardiovascular events and all-cause mortality with baseline NT-proBNP and troponin I levels and changes from baseline to 6 months in patients from HELIOS-B and explore how vutrisiran impacts biomarkers over time. Why it matters? Again, biomarkers may help guide therapy in real time. We need to know more about this. What they found, baseline NT-proBNP and troponin I levels were independently associated with the risks of a composite outcome and all-cause mortality. At month 6, increases in NT-proBNP from baseline were associated with higher risk of the composite outcome and all-cause mortality, and decreases in troponin I were associated with a lower risk of the composite outcome. Study authors say, quote, the relationships between NT-proBNP and troponin I and adverse outcomes in patients with ATTR-CM are complex and nonlinear, and also suggest the potential for absolute risk reduction from baseline. Treatment with vutrisiran maintains stable or improved levels of NT-proBNP and troponin I, which supports the clinical benefits observed in HELIOS-B and the link between stabilization of cardiac biomarkers and improved outcomes for patients with ATTR-CM. There was an editorial by Mitchell, Nakamatsu, and Chung in which they looked at cardiobiomarkers as an early warning system in transthyretin cardiac amyloidosis. Here's what they say. Because NT-proBNP levels and early changes in those levels were closely correlated with cardiovascular outcomes, this study helps affirm that NT-proBNP may be a useful surrogate endpoint in ATTR-CM and serve as a forewarning of future cardiovascular events and death. More specifically, increasing NT-proBNP at 6 months helps identify patients at highest cardiovascular risk at a relatively early time point. Earlier identification may prompt additional heart failure therapy optimization in interventions or refinement of patient-clinician expectations of the patient's clinical course. Look, here's my view. It's gratifying to see that biomarker changes align with outcomes. This could guide future escalation strategies. We need just a lot more validation to really understand how we should best use these biomarkers. Meanwhile, many people will be using them in practice, but we need more evidence. For this mini focus issue, we also selected a variety of pieces from across the JACC journals that were very relevant. Fontana et al. And JACC Imaging looked at a decade of insights into amyloid pathophysiology, imaging metrics, and monitoring therapy. Griffin and others in JACC Heart Failure looked at the therapies and put together a map of stabilizers, silencers, and depleters. Also provided key considerations for sequencing and switching. Bart et al. In Advances present an expert consensus on frailty and amyloid, highlights overlap with aging and heart failure, and emphasize multidisciplinary care. All of these papers are not just fillers in JACC, but they're actually substantial contributions that help fill out our perspective on this condition. In addition, we had a couple of case reports from JACC Case Reports. Tag team rounds had talked about timely diagnosis for team-based care in amyloid and showcases the diagnostic power of collaboration. In another one, it talked about the great imitator, how amyloid can mimic sarcoidosis. The imaging in this case was misleading, and biopsy clarified the diagnosis. These all add depth and reinforce what our original research is showing us. So what did we learn in this issue? Well, let's go starting with the beginning. Vasovagal syncope remains frustratingly elusive to treat. Compression therapy isn't a silver bullet, but well-conducted trials can still teach us a lot. DOACs can help frail older patients, but must be chosen with care. Shared decision-making is essential. Vutrisiran preserves cardiac function in ATTR-CM. That's not just about EF. It's about outcomes. NT-proBNP and troponin tell a story. Early changes may predict a response and help guide therapy in ATTR cardiomyopathy. And finally, amyloid care is evolving fast. It's no longer just a mystery diagnosis. It's no longer a death sentence. It's a disease we can monitor, modify, and manage. So that's it for this issue. Thanks for listening to JACC This Week. From compression therapy to anticoagulation, from imaging to biomarkers, this issue highlights how cardiovascular science is pushing forward and, particularly, why we must ensure access keeps up with innovation. I hope you've enjoyed it. Until next time, stay curious.